Thanks, Khaled. It's Frank Work here. Brian and I are both really pleased to be doing this. We think, as Khaled said, we've kind of had either the good fortune or the bad fortune of developing EHR EMRs maybe faster than some other jurisdictions, and as a result of that, we've had the opportunity to learn a lot, but we've also had the opportunity to see a lot of stuff go sideways on us. And I guess this webinar will be about the stuff that goes sideways. NetCare, which is what we call what the Alberta Electronic Health Record is now called. NetCare has about 20,000 users currently spread across the healthcare system. NetCare is a fairly comprehensive record now, and it includes everything from baseline health information to pharmaceutical information to imaging, and there are other specialized databases that are attached to it as well. So it's become quite extensive. It's a very rich database. There's a lot of stuff on it. And as we said, there's a lot of users. Aside from the immediate users of NetCare itself, we also estimate that about 50% maybe of the physicians in Alberta are on their own form of either electronic health record or electronic medical record. So there's a lot of take-up. I mean, anecdotally, I can tell you that I think most users like it, although the docs sometimes have reservations about where it's going, I think. But most users like it. But with the richness of the database and the large number of users, there's been a lot of opportunity for things to just go very, very bad. And that's what we're going to talk about. So our agenda, we're going to talk about what a privacy breach is. We're going to talk about the kinds of breaches we investigate, how to prepare for a breach. You might as well, because it's going to happen. What to do when, not if, a breach happens, how to avoid a breach in the first place, and how to learn from yours and others' mistakes. And I think what is a health privacy breach? It's not most of what we are going to talk about is, of course, under the Alberta Health Information Act, and I'll make a bit of a reference to PHIPAA subsequently. But a privacy breach is not defined in the Health Information Act, the HIA, but a breach occurs when someone collects, uses, or discloses those magic words: collect, use, or disclose health information in contravention of a privacy law, whether it's deliberate or accidental, or when an organization, custodian, or trustee loses control of personal information, or when the confidentiality of health information is compromised. Since there's no mandatory breach reporting, we find out about breaches in various ways. We've been surprised. The healthcare sector, Alberta does have mandatory breach reporting for the private sector, and it's the only jurisdiction in Canada that does. And it's interesting comparing how the private sector responds to breaches as compared to how the health sector, if I can call it that, responds. And we find, for example, there's a very high degree of self-reported breaches from health professionals. And you can speculate on what the reason for that is, whether it's the fact that most healthcare professionals work in an environment of confidentiality and are maybe more sensitive to breaches than maybe other professions are. I don't know. But we get a lot of self-reported breaches. And of course we get, because the Private Sector Act, which is PIPA, Personal Information Protection Act, has mandatory reporting, we get breach reports from the healthcare providers that are subject to that. I won't go into the distinction between being a healthcare provider under the Health Information Act and a healthcare provider under PIPA is just nightmarish. So I'm not gonna burden you with it, but it's confusing as hell sometimes. Interestingly enough, a lot of times breaches are reported by patients, and in a couple of the more notable ones, a couple of the ones that we're trying to prosecute. Well, we have prosecuted and are still working on prosecuting them. It'll turn out that the patient will find out, often through friends and associates, that someone seems to know a lot about their health situation, and then once their suspicions aroused, they start asking around, or they avail themselves of their rights under the Health Information Act, and they go get a copy of the audit log for their file, and they start noticing, that people who would seem not to have any right to do so are looking at their health information. So I think it's just interesting that it happens that way, but it also says to me as a commissioner that with all these users on the system, a small office like ours isn't able to police the system rigorously, and so you really do depend on the ability of individuals to know what's going on with their health information, so that they can let us know when they have a suspicion that something's not right. So I mean, part of the whole privacy protection thing is bound up in the ability of patients to access their information, and I think that's both a strength and a weakness of electronic health records. If we ever do in Alberta get to a functional patient portal, I think the fact that patients will be able to monitor their own records will be extremely important in terms of protecting privacy. And of course, the same as in Ontario and elsewhere in Canada, there's always the front page horror story of lost records that are found blowing down the street, or found in a dumpster, or found in an abandoned premises. We wish they were always delivered to us, but of course, human nature being what it is, they often get delivered directly to the nearest media outlet, whether print or electronic. We respond to breaches typically by an investigation. Our first concern is always whether or not the breach has been stopped or contained. We look at whether reasonable measures have been taken to prevent the recurrence. Were sanctions applied to people where there was fault? And most importantly, are the affected individuals informed? Informing individuals in healthcare breaches is really problematic. Health information, of course, is, I think everyone agrees, very sensitive. It's not always, the loss of health information doesn't always pose a risk to an individual. So even though it's very sensitive and people are justifiably angry and frightened and upset when their information gets lost, it's not like losing certain financial information, for example, where that poses a risk to you. So we always have a bit of a dilemma about whether or not to notify or whether to require notification in certain cases of breaches. And Brian will tell you about a couple later where we actually we didn't require notification. But it's a real dilemma. I know PHIPAA has a provision that requires notification, so that may take it out of your hands. But it's trying to judge the degree of risk that a breach presents to individuals is very, very challenging. We usually, when we respond to a breach, we do a public investigation report. We're less interested in shaming organizations that experience the breach than we are about educating them and other organizations about what happened. We might as well learn from each other's mistakes. We can hold a hearing, which can lead to an order against a healthcare provider, a custodian, to do certain things. And we do have an offense under the Health Information Act. The offense, you'll see under the bullet there, the legal requirement for the offense is knowingly contravene the act, and that's a fairly high standard. When an offense requires knowledge, it means that you can't commit the offense accidentally or in ignorance. It means you have to know you're doing something wrong. And that's, as I say, that's a high evidentiary standard to prove in court. And we'll touch on that a little more later, the implications of that requirement of knowingly contravene the act. And it provides for an up to a $50,000 fine. There are challenges in electronic health records. The root cause is sometimes hard to find, especially systems that are spread out. Back in the day when the possibility of a pan-Canadian electronic health record was first mooted in the late 90s, I guess, there was this vision that it was going to be kind of people suspected it was going to be some kind of a mother computer housed in a massive underground facility somewhere that, everyone's information would be on, which of course was, in hindsight, is absurd. But at least if it had have been the mother computer, in terms of protection and diagnosing breaches, we would maybe have a little easier time. The system is so complex that, finding whether it's the viewer, the feeder system, the network, can be really, really challenging. And the same with custodian boundaries. The 20,000 users of Alberta NetCare, they're almost like a spider web kind of a network. You get your privileges to access the information in NetCare depending on who you are and what your relationship is to other healthcare providers, and what degree of access you've been granted, depending again on who you are. And it's sort of like a CSI television kind of investigation, sometimes trying to follow the spider web to find who may have been responsible. But we do know that you can't underestimate the importance of policy and training. It's just, with that many users, no commissioner's office can and no management can effectively police that big a system with that many users. You have to rely on many different sources of feedback to find out if there are breaches, as I said. But more importantly, you just have to have policies and training in place, and you have to enforce them. And this goes back to that bit about the offense being one of knowingly misusing the health information. We recently had a case, in fact, where we on the facts, we believe we had someone pretty much dead to rights, that they were surfing other people's health records. But when it came time to look at whether or not we could charge them, we started looking at this notion of did they willfully do it? And it turned out the place where this healthcare worker worked had not given them any training. So right away, that gives this person the ability to say, well, I did not do it willfully because I didn't know better, because I didn't have any training. So not only and as a result, we didn't proceed with prosecution because we didn't feel that we would be able to prove that they willingly, knowingly were surfing the records. So, training becomes very, very important, not just as a preventative measure, but if you have to go to court and prove that somebody deliberately breached the rules, you got to be able to prove that they knew what the rules were. So training is absolutely critical. health privacy breaches, we gave you some numbers, and unhappily, you will notice that the numbers are, well, self-reports 47, 43 last year, and these are fiscal years, so we've had 32 year-to-date this year, and we still got 4 months to go, so that's not real happy. Complaints, 26, 26, and 13 at this point in this year, and offenses, 1 in 9, 10, 4 in 10, 11, and year-to-date 2. Now I'm going to turn it over to Brian now.
Thanks, Frank. So I'm going to give you a little bit of background on the kinds of the breaches that we typically get reported to us or we discover through self-reports from custodians. So I'll go over these in a bit more detail, but they're generally in these broad categories. We look through our records from the last few years. We've got shredding and disposal mishaps, data, so electronic data that's lost or stolen and it's not encrypted.
It's never encrypted.
Yeah. Misdirected communications, like faxes, emails, malware, viruses infesting computer networks. And the last one is a real bugbear, and we're seeing a lot more reports of this as more and more users are beginning to use these systems, is the insider abuse of health records. Interestingly, while we have had malware problems with viruses that will expose information to outsiders, we don't see any evidence or at least no reports of investigations of deliberate hacking attempts to get into electronic health systems. We're sure they're trying, but at least so far we haven't had any of those kinds of investigations. So I'll start with I think the first two, the shredding and disposal and lost and stolen documents, are kind of no-brainers. My advice on both of these would be don't do it, but we simply have, we're still getting reports of records found in dumpsters, things found in the trash can. So, the typical scenario, the records are blown in the wind. And what's happening also we see is the records get forwarded to the media, and then someone calls us. So it's not a very happy situation for the custodians or health service providers who are affected by these. And the causes are simple: lack of awareness, carelessness. The cleaners pick up the wrong box. They pick up the shredding box and they think it's recycling. It happens over and over.
We had one, sorry to interrupt, Brian, but we had one where it was a clinic in a small town in southern Alberta. You remember that one? Mm-hmm. The clinic had either gone out of business or been bought out, and they just walked away and left the server in the premises, and the landlord came in and found it, and there it was. I think eventually the leasing company had taken possession of the computer, so we had to go to Ontario to try to get this computer wiped. Luckily, the leasing company that seized the computer were very cooperative. But I mean, it's the disposal thing. I mean, you're still responsible for them, even after you quit working in Alberta now.
Well, and actually, that's a good point. We had the leasing company being cooperative in that case. We had another case where the leasing company and the physician were in a bit of a dispute, and they weren't cooperating. So the leasing company actually, in their minds, they seized the records, and then they reported the incident to us, and the physician had a terrible time getting his records back. So, not good. So the next one we see pretty commonly is lost and stolen paper documents. These come from unsecured, informal filing areas. We've had investigations where, like I've quoted there, the records are piled, by a nursing station until someone can get to them, and they may go missing, or they may be viewed by, family members or people on staff happen. Workers take work home, papers are stolen from their car when their car is also stolen. Files are left on the bus or on the train, and attempts are made to recover them, but they're often not very successful. And then usually what's happening there is that the custodians affected by those are in the unfortunate position of deciding that they better inform people that their records are lost. So now we're getting into some more technical stuff, although the first one there on misdirected communications is an old one, wrong fax number. It's surprising how many physicians have numbers that are just one digit off of many media outlets.
Yeah.
And we still get those reports. And of course, besides wrong fax number, we have wrong email, so you send the information to the wrong person. Email where you hit reply to all, and then the information goes to the wrong people or a wider range of people than it should have gone to. Those are, I think people know about those. I mean, I think people know what to do to avoid those. I mean, you can program your numbers into your fax machines so that you're not dialing things because of your fat fingers, or and you have to check those program numbers, of course. Wrong email, that's just inattention. Same with the reply to all. An interesting one that we're seeing now is data mix-ups in some of these systems. So the wrong report is sent to the wrong physician. So reports are going to physicians who didn't request them. Those get reported to us, and it's kind of interesting. The physicians who got these records didn't want them. They don't know what to do about it, and in some cases, the systems that are feeding the data to them, they can't turn it off. So they keep on receiving these wrong reports, which puts these physicians at risk. I mean, now they're stuck in the position where they've got all these records they never asked for, but they've got to do something with them, either dispose of them or who knows what. They at least have to safeguard them. So it's a tough one, and we are seeing that more. That's, I think, something where with all of these interconnected systems, these mix-ups are actually likely. One of the causes of these kinds of mix-ups, of course, is systems updated or improved. Didn't see my air quotes there, but the systems are improved on the fly, so they're not updated with appropriate change controls. The data is not tested before it's made live. Another area where we've issued an investigation report on things like wrong fax numbers or insecure emails is, for example, on a wrong fax number, we had the sending party and the receiving party both had access to NetCare. They could have sent the information by way of NetCare because it includes a secure messaging channel, but they were still kind of stuck in the 80s and using fax machines. So we encourage custodians to use secure channels, like in the provincial electronic health record where available. The next one, as Frank said, it always still seems to be unencrypted. Lost and stolen USB sticks, laptops. We've issued, at least 3 investigation reports on this, advising custodians that, passwords just aren't enough. We need to see properly implemented encryption, or we're really going to be expecting that they inform the patients that they've lost their information. What happens on these are some common themes we see in cases where data is lost without encryption. We have a policy direction that asks staff to encrypt health information, but they don't give them any tools or training, or they point them to a website, but there's no actual instruction provided. So the policy itself is not enforced. The decision is made to give someone a mobile device without considering the risk. We had one investigation where staff were taking data home on a laptop that was unencrypted. That's bad enough, but they weren't just taking home what they needed, they were taking home the entire database. So when they lost it, they lost everything. And of course, once again, this is similar to my previous advice on faxes. If you've got a secure channel, use it. You can set up your mobile devices to dial in to the databases that you need to use securely and have no data left on your device. So if it is lost or stolen, you've just lost your device. You haven't lost the data, and you don't even really have to worry about whether it was encrypted on the device if it was never stored on the device in the first place.
I mean, we know, look, people lose things, right? If you go to the Toronto Transit Commission or the Edmonton LRT, go to their lost and found someday and just ask to see what they've got, and you will see like 10,000 cell phones and iPhones and laptops, and it just, people lose stuff. We are idiots when it comes to this. So, you know, I mean, Commissioner Kavukian in Ontario has said many times, don't collect it or don't carry it with you in the first place, and that's half the battle. But if you've got anything as far as I'm concerned, if you have any personal health information on a portable, the reasonable standard is encryption, and if you fail to encrypt, you're in breach of the Act. It's just got to be that way because we are idiots. We lose stuff. And the smaller the device, the more likely we are to lose it, although, anyway.
Yeah. So the next one is malware, so that's viruses, Trojan horse programs, those kinds of things that will, you know, get into your computer systems, infect them in various insidious ways, and allow outsiders potentially to take control of your computers and gain access to health information. And we have published two public investigation reports on this topic, and they're a good contrast if you want to visit our website and take a look at them. In one case, we felt that the custodian had reasonable measures in place, but bad things still happened. And in the other case, we saw that the custodian had not met their duty to protect health information. And when we see these kinds of problems, here are some of the common causes. People are not keeping their computer systems up to date or patched, as we say. So, you know, you have an older operating system, or even if you have an older operating system, you're not keeping it up to date with the manufacturer's updates. The other things that sometimes is forgotten is you also have to update and patch your antivirus and your definitions of your viruses. What allows the viruses to spread when they come onto one computer is if you have computers on your network with administrator privileges, which means that those people have the ability to install and execute new programs such as viruses. So if you have a lot of people set up with those advanced or accelerated privileges on their computers, the malware can spread much more easily. The other thing that I saw in one of these investigations is the custodian had a very poor understanding of their infrastructure. They were involved in partnership with with a university, and the university was managing some aspects of their infrastructure. They were managing others, and one of their servers, they were aware that it might have been a bit out of date, but they didn't really communicate effectively with their service providers. Their service provider didn't really realize what was going on that computer, that it contained actual health information, and didn't think it was important to patch, and then they got owned by viruses, and it was really too bad. It just kind of slipped through the cracks, because otherwise things there were managed pretty well. So that's what can happen. You really have to be conscious of what's on your network. The last one of these very common things we're seeing is the insider abuse. And I'll tell you right now, we've noted that the gateway drug for insider abuse is looking up yourself. So that's not necessarily a horrible privacy violation, but that's what people always, who go on to do worse things, always seem to start with. They start with themselves. They look up their friends, their family, then they move on to their enemies. We often see, unfortunately, a love triangle, divorce proceedings, custody battles are at the root of these. And maybe people are discovering these because they are involved in these disputes and they are a little bit more alert to suspicions. That whole idea of someone seems like you're dealing with someone who knows a little bit too much. So sometimes people get suspicious and then they request an audit log of who has looked at their health information. And that's one of the interesting new things that's been added to our Health Information Act, is that people can now request a log to see which custodians have looked at their health record in the provincial electronic health record system. So people are increasingly getting those reports and seeing healthcare providers they've never heard of looking at their health record, or ones that they have heard of that are actually people they're not too friendly with, and then they report the incident to us. The other, I think, encouraging thing is that some custodians are conducting their own internal audit based on, predefined criteria. They're just doing some random checks, but they're also looking for suspicious patterns, and they are identifying insiders who misuse systems. So some of the issues that we see here, Frank's alluded to some of this. I mean, training is key. Training's not going to stop the rogue, but it will stop, or it will make their life a little bit more difficult if their coworkers are aware of privacy and security, and they might see someone misusing a system or jumping on someone else's account and trying to misuse the system if they're more privacy aware. The lack of training and user agreements it not only hinders us in our investigations or pursuing an offense, it also stops custodians from administering effective discipline, once again, if they've never or not recently trained their employees, who then go on to misuse systems. The other thing that makes it really difficult, both for custodians in discipline as well as for us in prosecutions, is people sharing their accounts or allowing others to use it. If we can't show that the bad guy is the person who had their fingers on the keyboard when the incident happened, they can always raise the possibility that someone else might have done it. Okay, so we're going to move on to Frank, and he'll give you some advice on how to get ready for a breach.
Okay, and apropos that last bullet, we have found that there's a real delicate balance. I mean, you need to have security. You need to have audit measures. You need to have rules about who can use machines, sharing accounts and so on. But we have seen in Alberta, we've seen users walk away from systems because they're overly complex or overly difficult to use. In fact, that happened with a major specialized system back in the early days here. The docs simply felt it was too difficult to use, so they wouldn't use it, and the system had to be mothballed at great expense because it was just too hard for the docs to get access to. So, you have to deal with that kind of tension between ease of use and security. It's not easy. Well, be prepared. This, in so many areas of risk management, the best advice is assume that you're going to have a privacy breach, and you should have. This is not, from our point of view, this is not about public communications and spin doctoring. This is having a breach response team ready to go, because if it does happen, you've got to move quickly. As far as we're concerned, our priorities are stopping the breach, stopping the flow, and mediating the damage, either getting the records back or advising people what's happened and what they can do about it. So you need to be able to move very quickly, and we've listed some people there: privacy officer, legal counsel, contractors. If you have an IT type of breach, if it takes you 4 days to run around and find the right consultant to advise you on what the heck happened, you're already way behind in terms of being able to deal with it. So you've got to have this team identified up front, and you have to know where they are, and you have to know how to get to them right away and how to brief them. Who are you going to inform? How do you decide whether or not to inform? Jurisdiction can be an issue in this a very complex networked world, and communications are the key. You should, it sounds maybe kind of funny, but you actually should sort of practice what you're going to do if there is a breach. Because seriously, it's incredibly embarrassing, and we've all seen it happen. It's incredibly embarrassing when you have the breach and it hits the media, or, well, it doesn't even have to hit the media now, it hits the internet, and your organization is standing there going, we're terribly sorry, but it's taken us 3 days to respond, and we're not exactly sure what to tell people, and but we're terribly sorry. You really have to be more prepared than that. You have to have your people in place ahead of time, and you know, any risk management program, you know, 3 or 4 phone calls should be all that's required to get your people moving on the breach. And then there's So
what do you do when it happens? Well, first thing is, this might seem obvious, but whatever's happening, stop it. Try to stop the tide of the breach. If you have information leaking, stop the leak. If you've lost information, attempt to recover it very quickly. Put your team together. Try to fix that problem. And you've got some immediate actions you can take. And some of them might actually involve suspending staff if they're misusing information. Establishing that investigation very quickly will also help you administer discipline later. Find out what happened. You want to learn from this in the long run. Analyze whether or not the affected individuals or the patients are at risk. What sort of information was lost? Is it sensitive? Does it also include financial information? Even if it's, in a lot of cases, it's health information. In our view, if it's health information, people do have a right to know. It's hard to tell what people would find sensitive when it comes to their health. So we certainly tend towards advising custodians to advise the affected patients of a breach. You should notify, of course, regulators. That could also involve professional colleges if you feel that's appropriate. Set up your plan to communicate with the public. We've seen some custodians communicate very effectively. They'll even go to the length, some of the larger ones will set up a 1-800 line with staff who've been briefed, who can answer questions, and start communicating. If you are going to make a report, and this goes for reporting to a professional college or somewhere like our office, these are the kinds of things you should include in a breach report. So basically, what happened, when it happened, what was the actual data that was affected, your assessment of the risk, how many people are affected, what are you doing right now to reduce the harm and then mitigate that risk of things happening again in the future. What is your decision regarding notifying individuals about what happened and whether they are personally affected, and then contact information for the person within your organization who can answer questions about the breach. And on our website, because of our mandatory reporting provisions under our private sector law, we do have a fairly extensive breach reporting form and guidance set up there. And what I just relayed now summarizes some of that, but you can see it laid out in a bit more detail on our website. And just some general advice when you are communicating with patients about a breach, apologize, be open and honest, tell them what happened, let people make their own decisions. If you feel let them know exactly what data is lost, let them make those decisions themselves. Don't assume that it's not that serious and people probably don't need to worry about it. That usually gets people's backs up. Tell them what you're doing to prevent it from happening again, It's very helpful if you have informed your privacy commissioner office that that you let people know that you have informed an office like ours and other authorities. It lets patients know that you've taken it seriously and that you're not trying to hide anything, and you are working with regulatory bodies to fix the problem. And make sure your frontline staff, whoever is dealing with this, whoever is picking up the phone, can actually answer questions in a substantive way about the breach. It's nothing worse than a stonewall situation like this if you're a patient. And last of all, of course, you want to learn from your mistakes. One of the things you can do is review investigation reports published by various commissioners' offices on all of the topics we've covered today. Encourage a culture in your organization of reporting near misses and things where you almost had a breach but you didn't. If your culture supports that, you will strengthen your ability to avoid breaches. And if you had the breach, don't be afraid to make it a case study and communicate those lessons learned internally. Okay, so we're back to Frank.
Yeah, avoiding breaches. Well, I wish there was a foolproof way to do it. As life is full of risks, and the best any of us in any organization can do is to manage risk the best way we can. And in this case, there are a few things you can do to try to manage your risk. And the first one is conduct privacy impact assessments for new systems. Under the Health Information Act in Alberta, they're mandatory. You have to prepare a privacy impact assessment in most cases, and you have to give it to us, and we look at it. But more important than us looking at it is just the fact that you've done it, that you've done the privacy impact assessment. You've looked at where your vulnerabilities are. You've looked at, hopefully, where your vulnerabilities are. You've looked at where your organizational problems might be, and so on. And that's half the battle, just knowing what your situation is. There's some other things there. You confirm your legal authority to collect, use, and disclose, understand your information flows, mitigate risks, review, and so on. And I mean, one of the we've said again and again this morning that a couple of the upfront things you can do to avoid breaches are, first of all, limiting the amount of information people have access to, or limiting the amount of information they're carrying, and that becomes apparent after a privacy impact assessment. Same with, the number of administrators you have or people with administrative rights. All those kinds of organizational things really can be identified in a privacy impact assessment and addressed. Security reviews, audits, penetration tests, important. But again, the tech stuff, you got to have it, and you got to have good firewalls, and you got to have good technology. But a lot of the breaches that we see are, the human factor. People lose things. People start surfing their own records, as Brian said. They start surfing other people's records. These aren't high tech crimes. These are very, very human kinds of behaviors, and you have to deal with those as effectively as you can. So again, review your policies, make sure your staff are aware of policies, train, make them aware, and keep your system as under control. I remember we had one, and it wasn't really a breach, it was a privacy complaint, and it turned out, for example, that back in the days when we had health regions, someone had given the entire law department of a health region full access to NetCare. And, the question was, well, why? Why do all those lawyers need full access to NetCare? And there wasn't really a good reason for it. They just did it because I guess the lawyers said, oh, well, we might need this someday. And that's the kind of thing you have to identify. I mean, that poses, having that many users who are possibly not specifically trained and possibly don't have real justification beyond the system, that's a huge liability. So just because you have this massive system, everyone will want on, of course, and you have to manage that because, again, the more people you have on them, the more risk you're assuming. At the end of the day, for example, in the Alberta Health Information Act, the standard of the duty to protect health information is that a custodian must take reasonable steps, and you have to protect against any reasonably anticipated threat. And the safeguards must include appropriate measures. And similarly, in PHIPA in Ontario, the standard is a health information custodian shall take steps that are reasonable in the circumstances. Look, as a commissioner, I know I'm a lawyer, and I know what reasonableness means. Reasonableness is not perfection. So reasonableness is due diligence. Reasonableness is what you could expect a normally diligent healthcare provider to impose. So I get frustrated with organizations that claim that, well, we can't afford to do all this stuff. We can't afford all this protection, and so on and so forth. I mean, you don't have to be perfect. You just have to be reasonable. So you need to define systems and administrative procedures and auditing and stuff that are reasonable under the circumstances. And if and reasonable means that you should be able to do it without having to seriously impair your system or render it useless to users. But you still have to do it, and you just I know organizations take a very hard hit when they lose information, both in the media and from the public, because it is disturbing and it's very painful usually for the people who are the victims. But the standard is reasonableness, and I think we just have to behave reasonably, but be prepared for the worst to happen. We have, in one or two cases, I have decided, and you see the news clipping there. I mean, it can happen, at least in Alberta, that you suffer a loss, and I might still find that you, despite the loss, you did behave reasonably. That sometimes doesn't satisfy the bloodlust of the media or the public, but it can happen. And I'm not saying this to let anyone off the hook or to suggest anyone go to sleep on this, but I think you do have to keep this in proportion, keep perspective on it, and build the best systems you can, but manage the risk as best you can. I think that's it. We've gone on about 5 minutes longer than we should have, but I think there's still some time for questions, however that works.
Okay, well, thank you very, very much. This was excellent. So now the attendees should see a text box on their screen where they can enter their questions. And as we're waiting for the questions to start coming in, I'll start off by asking the first one. You mentioned the poor version control on some of the systems as a reason why some breaches occur. I was just wondering if you can explain that or expand on that a little bit. I thought these systems were certified and all the changes have to go through some kind of certification, which would, I'm assuming, alleviate some of these risks.
Yeah, many of them are. For example, the physician office systems have pretty strict certification processes, but other systems aren't. And I think some of this has to do with the complexity. Is one of your partners or somebody, 3 systems down the road from the system where the problem actually manifests itself, they do a little tweak, and they don't realize that that tweak is going to cause problems in other systems that are connected. And so, yeah, we do see that. And the kinds of breaches that we see, like I say, they're mismatched data. So data will go probably to the wrong place, but it's still within the healthcare system. So they're not necessarily horrible privacy breaches, but they do give custodians a problem to deal with. And of course, the real risk and the real worry with these is they can be a risk to patient safety.
Okay, excellent.
No, we got some stuff here.
Yeah, so if you can read the question and before you answer it, that would be great.
Want me to read them? I'm a little closer to
Yeah,
the
Brian,
screen.
closer to the monitor.
Okay, so we have a question. What would you consider current privacy training, yearly or every 3 years?
I would say you should have your initial training session either when you initialize the system or with new staff, and then there should be a refresher at least annually.
Yeah.
3 years is too long. People forget. They need to be reminded. And you can, the refresher can be online. You could develop an online module or something, and I do think the initial training, wherever possible, and I know we're talking about a lot of people here, but the initial training, if possible, should be face-to-face. I think for some reason, given human psychology, the face-to-face factor makes a better initial impression.
Okay, so what criteria are custodians using for proactively monitoring access logs?
Yikes.
I can name some of them for sure, and we don't want to give away too much, I guess, but we're like I say, the gateway drug is looking up yourself, so custodians are checking for people who are looking up others with their own name or same last name, and that's not going to cover everyone, obviously, but it might detect patterns of behavior. They're looking at people who have asked to see their records masked, and they're looking at the unmasking decisions. So if people want their records, with additional privacy protections, and those are removed, those things are reviewed. Famous people are monitored often on a routine basis, or even if there's a lot of activity on somebody's record, that will be reviewed. So the person might not even necessarily be famous, but they might be, for some reason people are curious about them because there's some local issues. So there are things like that. It's not perfect, but we are seeing increasing reports of those proactive monitoring. Next question, are the people responsible for training liable if the breach occurs and the employee claims they had no training?
Yeah, I think there is. Well, there are two answers to that. First of all, the general provision in both PHIPAA and the Health Information Act is that you must take reasonable steps to maintain administrative, technical, and physical safeguards. So I would argue that training, although it's not specified, and under PHIPAA, a health information custodian shall take steps that are reasonable in the circumstances, etc. I think training would certainly be included in those reasonable steps. So if you don't train, my suggestion would, not knowing anything else, would be that you're in breach of either PHIPAA or HIA. You're in breach of the duty to protect provision.
One directed to me. If data is accessed by a network connection, are temporary files written to a local disk on a PC or laptop? And is this of concern if that device goes missing? So the short answer to that is yes, that would be of concern. Sometimes temporary files are written to a local disk. Sometimes they are, and sometimes you can avoid that. Obviously, if you are having temporary files written to your disk in some fashion, or speaking more generally, if some data is left behind, if you're accessing health information remotely, ideally you'd employ something like whole disk encryption so that whatever's on your computer is encrypted. can you describe the difference between a data steward and a custodian in an EHR environment?
Go for it, Brian.
That might just be terminology. Data steward. We have in our law, we have custodians who are responsible. They're basically on the hook for Health Information Act compliance, and we have other bodies who have some stewardship role. We call them information managers here. They basically be like IT service providers. Anyone who's storing the data on the custodian's behalf. And so we would view that, the custodian is responsible, the steward has a role, or the information manager has a role. They have to follow the custodian's directions, though, and they have to have an appropriate agreement in place. And in investigation reports in Alberta, anyway, we have investigated the custodian, and we've said, the breach lies with the custodian, the responsibility is there. But we've also investigated their information managers, and we continue to do so, because they also have a duty, under our law at least, to comply with the Health Information Act, just as the custodian does. Please clarify the requirement for encryption. I gather it's vaguely implied in legislation under reasonable, and that there is some communication from the OIPC encouraging encryption, but no details.
Well, I would say it's a little stronger than that. Again, as the question rightly says, it's implied under the duty to protect provision, and I think just about any privacy law in Canada has a similar duty to protect provision. Our interpretation of this in Alberta is that if you put personal information on a portable device, whether it's a stick or a disk or a laptop, you must encrypt it. That is what we have decided is the reasonable step in that circumstances. And yeah, it's not legislated. It's kind of a interpretation of the duty to protect provision. But I think, given the astounding record of lost devices in this province and in others, you pretty well have to be blind not to see that that's where probably one of your greatest vulnerabilities is human beings walking around with portable devices and, of course, losing them. So it just seems axiomatic that you must encrypt, because you must assume that we're going to lose whatever device you give us.
There's another related question to that, just specific about a particular product. iPads are now used in healthcare. From my understanding, there is no encryption software that secures this type of hardware. Can you please clarify how iPads are used in healthcare throughout many organizations in Canada?
Ooh.
Well, I think, there are ways to secure an iPad, but you certainly hear a lot of reports that they're not as secure as you might think. I'm not an expert on iPads per se. I mean, once again, you have to, like our advice would be, do the risk assessment, contact somebody who knows about iPad encryption, see if there is a way to deploy it securely. Maybe you can access information through a secure virtual private network instead of storing data on the iPad. That may be a better option for those kinds of devices. But without making any recommendations on any particular kind of device, do your risk assessment. Be aware of what the risks are. And if you can't secure your device, I wouldn't recommend that it be used. Although the reality is we know these things are being deployed, and maybe not with much security. So that's one where I think we'll just wait and see until there is a problem.
Yeah.
Gentlemen, we have a lot of questions. Do you have time to continue answering?
Yeah, I do.
Oh, okay, that'd be great. Okay, so let's just keep going then.
Okay. Next one. Given that so many breaches involve the exposure of health information on a purportedly secure website, who should bear the responsibility for monitoring this kind of exposure? Management, regulator, or the public?
Well, I think the lawyer's answer is the the duty falls upon the entity that is in control and custody of the information. I don't think, that's just the way it has to be at this point. Regulators, I mean, we have 5 people in health information. We can't police all these things. And 20,000 users on NetCare in Alberta, hundreds of thousands of transactions, data transactions a day. It's hard to expect individuals to police this, so it's got to fall to the network, the owners of the network, so to speak, and that's the custodians, and as Brian described, the system, the managers as well. I think the promising thing, as I said earlier, is when and if some jurisdictions like Alberta start developing a patient portal, a truly interactive patient portal, people will be able to see more about their health information and possibly even be able to see who's accessing it, and that'll be a tremendous thing for policing the electronic health records. But I don't know, we're probably 2 or 3 years away from that. So in the meantime, it has to fall to the custodian.
Next one, if police call for information on a patient, what information can you tell them? So, not really related to a breach, but it comes up a lot. Yeah.
Well, it depends on the legislation. In Alberta, there are specific instances in which you can disclose information to law enforcement. As a general rule, and I'm not sure what PHIPAA or any other the other provincial statutes say, my inclination here in Alberta is that if the police have someone of interest and they want to know, I don't get too upset if a healthcare provider discloses basic location information. So, for example, if an officer came into an emergency room and said, do you have this such and such a person, they might not have a name, but such and such a person here, and if you answer yes, and if you give them a name and nothing more, so that the police are enabled to go away and get a warrant, a search warrant, or that's the preferable situation to me. I know the police complain a lot about not getting access to health records and feeling, one police officer here in Alberta said hospitals will become havens for criminals, which I thought was a bit of an overstatement. But, if you have to give out information to the police, I would give them just the minimal that enables them to go away and get a warrant, a search warrant. And then once you're presented with a search warrant, it's out of your hands. You obey the law and you do what the warrant requires.
So our next question says, obviously training is a major piece of risk mitigation. Do you have templates or information on the core pieces you'd recommend including in initial and annual refresher training? Also, is testing mandatory to ensure they've understood the concepts? Our office hasn't published any training templates here. Oftentimes, your training has to be customized to your specific policy environment and the information systems your staff use. But we have provided advice and consultation on a number of training programs that custodians share with us. One example is through the Physician Office System program that we're very happy with. They have an online training program that they shared with our office and we reviewed. So there are examples out there, and often custodians as public organizations are happy to share them. Is testing mandatory? Well, it sure helps if you're trying to prosecute an offense or discipline an employee. You might offer training, that they, especially if it's online, that they click through in 5 minutes. But if you have a test at the end, it gives you a little bit more strength to say that, training. You stated that initial training or education should be face-to-face. What are your thoughts or opinions on e-training for the initial training education?
It's a factor of dare I say, reasonableness. I mean, if you've got, tens of thousands of employees that you have to train, it's obviously could be very resource consumptive to get them all in one room and shake your finger at them. If you can do that, I still believe that psychologically the initial face-to-face contact is preferable. But if for resource reasons or logistical reasons you can't, online training is not a bad option. You just do the best you can. I think, although, apropos of the last point too, if you are going to train, you have to train, and you need to take attendance, right? Or you need to have, whether it's in face-to-face or online or whatever it is, correspondence, I don't care. Even if you give them a package of paper when they walk in the door and tell them to read it, you have to record the fact that people were trained. And that becomes very important if you ever want to prosecute. You've got to be, when you're trying to prove that the person willfully did something, you have to be able to go in and say, yes, Frank Work was at the training session on November the 13th, and he completed the module and signed off on it and so on. You have to be able to meet that threshold evidentiary burden.
So here's one I'm pretty sure you'll have something to say about, Frank. Given that PIAs are mandatory under the HIA, should breach reporting also be mandatory? What are the lessons from PIPA?
Yeah, it's a good question, and my answer is yes. I think breach reporting should be mandatory under HIA. It's not. I don't know if I can't remember when the next review of the HIA is due, but if I were still commissioner, it's certainly something I would push for.
Are there any lessons from PIPA? That was the second part of that question.
Yeah, there's a lot of lessons. If you want to, actually, that raises a good point. If you're interested in seeing how a commissioner views various breaches, if you go on our website and don't look under HIA, but look under PIPA, P-I-P-A, you'll see all the reports that we issue from the mandatory reported breaches. And you will see in some cases where we don't require notification after a breach, and you'll see in the cases where we do. And it might give you some idea of at least our view of what kinds of risk arise from what kinds of breaches. I mean, there's no magic formula for this. We did an exercise with a lot of stakeholders about breach notification, gave them a bunch of scenarios and said, okay, which of these scenarios do you think pose serious risk or serious harm? And interestingly, people in law enforcement, not surprisingly, thought that just about every breach raised a risk of serious harm, whereas people in business didn't agree. They tended to see the most egregious kinds of breaches as posing the biggest risk. So, it's not an exact science.
Review of audit logs. How do you see this working in a community pharmacy where there may not be regular patients? Yeah, that could be tough. I still think there are some things you could audit for. You could certainly check to see if staff are looking up friends and family and
Same name audit.
Yes. Is there a lot of attention focused on one particular patient by a whole bunch of staff, or repeated lookups of particular people? You could in a pharmacy, you might actually be able to do timing audit log reviews. So if a particular patient isn't in looking for prescriptions, then why is someone looking at their records? That might be an interesting question to pursue. I think a pharmacist might be able to answer that question a lot better than we could. they understand the normal pattern of their business, and that's what you want to look for, is things that fall outside of that typical pattern of prescription and dispensing.
Yeah, I would certainly look at same name, and then, as Brian said, I would look at repeated visits. If someone is going into someone else's health record repeatedly, I mean, it can be because they're under care, but it can also be because the intruder is monitoring the victim's progress through a disease or a medical condition.
Okay. What is the best approach to address a breach if the breach concerns disclosure and contravention of the legislation that a custodian believes is not contravention? I think that's, so they put in brackets here, it's the disagreement between the custodian regarding the disclosure practices. So we've got a contravention, but the custodian believes it's not a contravention. I guess if there's confusion or whether you're not really sure there is a breach, our counsel would be, give us a call. Call your privacy commissioner's office. It may not be the same across Canada, but certainly in Alberta, I mean, we have a pretty good relationship with folks in the health sector, and we can have a frank and honest conversation with people, and it's better to call us and ask for some advice informally rather than assume you don't have a breach and then have it hit the newspapers the next day.
Yeah, that's a tough one.
Yeah. What's an example of encryption software that we should inquire about using? Is there one or several types used by most institutions or universities across Canada? We don't really, I wouldn't say that there's any particular product. Both Windows and Mac now include encryption in the latest versions of their operating system. So, but that doesn't always work for a large institution, and that's where we recognize that implementing encryption in a large organization can break other things, and it's a very complex process. So there you're going to be looking at some of the larger application or service integrators, systems integrator companies who can do that kind of work for you. For the individual user, like I said, you can encrypt your full laptop with either Windows or Mac, no problem, and Linux too.
And otherwise, in a larger complex system, you're going to have to go to your advisors, your technical specialists. But there again, as Brian said, you have to balance things. I mean, don't let I don't know what the standard ISO or CSA, I don't know what the standard is now. It's 256-bit was the last one I heard. If that is a reasonable measure of protection, then that's what you go with. You don't have to go to the total the total ultimate absolute shutdown system. Reasonable is reasonable, and the words are always reasonable and as appropriate in the circumstances. So you're allowed to balance your encryption with the information you have, the vulnerabilities of your system, and so on. But that's a thoughtful exercise. You probably do yourself a disservice if you just run out and buy the most expensive, complex system you can find. You really need to have a conversation with your experts and find something that is reasonable and workable.
This is a good one. What recommendations do you have when information is collected using devices that do not have any encryption capacity? So, for example, digital cameras or video recorders or audio recorders.
Oh, yeah.
I mean, I think that there we're back to old school privacy principles. Only collect what you need and only keep it as long as you need to. So something like a digital camera, I mean, don't just store information on there indefinitely. Take the pictures you need to and then get them off of the camera and into a more secure environment. So no encryption while you're still into use limitation and appropriate
that leads me to a related issue, this whole issue of orphaned records. When you and this isn't directly an encryption issue, but you know how fast technology changes, right? And in your office, your organization, your clinic, whatever, where are your old devices? What happens to your old servers? What happens to your old PCs? Where are they? Are they, do you send them out to the flea market, or do you store, put them in the closet and walk away from them? What do you do with this stuff? The remediation of your information technology is just as important as anything else. And again, we found not only boxes of records lying around, but laptops and old PCs that have just been abandoned because they became outmoded, and that just shouldn't happen. Alberta has actually taken some steps. I'm very pleased. Alberta has taken some steps to give the healthcare colleges responsibility for regulating this with their membership. And I don't think the measures are in force yet. Brian says no. But when they do come in force, for example, the College of Physicians and Surgeons of Alberta will be responsible for making practice rules for doctors as to how they dispose of records at the end of their life. And that's a very important factor.
Another technical one. Many electronic systems are purchased with predefined user roles. Have you had any issues with this, resulting in some users having more access to personal health information than is reasonably necessary for them to perform their job? Well, Frank had a really good example earlier when we had people in the legal department having access to NetCare, and it wasn't really in alignment with their job. We've had other cases where staff are using NetCare for more employment reasons rather than healthcare reasons. And so once again, you see roles, their role is defined in one context as having to use, a system like NetCare, and in another context, they're using the information for another role that really isn't included in, what the system designers anticipated. So it does happen for sure that you have people with a bit more access than they need. The offense that we successfully prosecuted a few years ago, we had a receptionist or an administrator in a medical office looking at health records, detailed lab reports and things like that, and it really didn't seem appropriate that someone in that role had access to that kind of detailed information. They maybe should have only had access to the demographic side of what's in a larger system. So it does come up for sure. Just a few more, actually. Do you have advice related to de-identification of information as opposed to aggregate for the purpose of working in an insecure environment, such as a home computer? Could you eliminate the requirement to encrypt by de-identifying information? I don't know, Khaled might have a lot more to say about that.
Yeah, we don't have, I don't think we've had a lot of experience with de-identification. To be perfectly honest, I don't know if anyone's actually doing it here or not. I know there's increasingly good technology for this, and it's a great preventative measure. But I can't really comment on how good the technology is for de-identification. And as I say, I don't think we have a lot of experience with it being done here.
Yeah, it doesn't usually show up in our office simply because our law allows custodians to collect, use, and disclose de-identified health information, for any purpose, essentially. So we don't get privacy impact assessments on that and so forth. So we don't tend to see it here, or we don't tend to get the opportunity to investigate whether information truly is de-identified. We see it a bit in privacy impact assessments, but
are.
All right, thank you.
Identification.
So we have a question now about our opinion on the use of cell phone and iPhone security in the medical field. Well, it's a portable device, so obviously it is susceptible to loss and theft. This comes back to your risk assessment. What are you going to store on these devices? Do you need to store anything on these devices? Is there some way to give people secure access to the information they need to do their job without leaving information behind on these devices? We don't really view cell phones or iPhones as anything different from a USB stick or a laptop. They're all mobile devices, and they can all easily be stolen and lost. So they need to have the same considerations applied before you start using them.
Yeah, you better, at the very least, if for whatever reason, and you better have a good reason, if for whatever reason you are allowing health information to be stored on cell phones, iPhones, Android phones, whatever, you better have that kill function engaged, because chances are someone's going to lose their device, and it better be mandatory and a matter of training that locational function is always engaged, so that the device can be remotely killed if need be.
The last question is actually a really tough one. So we saved one of the tough ones for last. More and more physicians would like to use emails to communicate with their patients. What is the OIPC's position on this? There's a lot of things you need to think about if you're going to start doing that. One is email is inherently insecure. So if you're not taking measures to encrypt it, it can be intercepted, viewed by others. The other thing when you're dealing with patients is, how do you know you're actually dealing with the person you think you're dealing with? So you need to authenticate the people you're communicating with. You've got records management issues to consider there as well. Where are your records going? Are you managing them? Are you seeing that they're destroyed appropriately? Are those emails going on the patient file or on their chart? Is it part of the treatment, or is it just to set up an appointment time?
Yeah.
So there are a lot of issues. The CMPA, the Canadian Medical Protective Association, has published some advice on that. I know some of the colleges of physicians are thinking about it. We haven't come out with a formal position, but the questions that I just posed are the kinds of questions that we ask when we see that in privacy impact assessments. And like I said, there's some old-fashioned stuff you can do aside from going right to encryption. Limit the amount of information by using forms rather than allow people to do free-form emails where they can say basically anything. And of course, a lot of electronic health record systems now are coming with secure portal arrangements so that you can communicate securely in an encrypted method with your patients. But those also bring to mind a number of management issues. Now physicians and hospitals start to have to get into the business of managing usernames, and people have forgotten their username and their password. How do you deal with that? So we're not saying it can't be done, but there's a lot of management and a lot of thinking that you have to do before you get into email communication with patients.
Yeah, I agree with all that. I mean, being able to communicate, I know from personal experience, being able to communicate with a healthcare provider electronically potentially holds tremendous benefits both for the healthcare system, the patient, and the healthcare provider. But not only are there clinical issues there, but there are these security issues. I think, as Brian said, I wouldn't say no, it can't be done, it shouldn't be done, but it has to be done in an awareness of the risk. I think the biggest promise in this area is probably active and secure patient portals. But I mean, that's not going to be a a silver bullet either. Those things, there's going to be vulnerabilities there too. I don't think you're necessarily doing anything wrong if, from a security and privacy point of view, if you do allow for electronic communication. But you know, it's the same story: due diligence and a privacy impact assessment, and rules as to, you know, how it's to be done. Not a real satisfactory answer, but as with any new kind of new technology, well, it's not a new technology, but new application of it, you got to tread carefully.
Yeah, we just lost our network connection, but someone, I just saw this pop up while we were answering the previous question, was, so how is this different from leaving people a voicemail? Well, in principle, it's not that different. You still need to make sure that it's okay to leave a voicemail at that number. You still need to make sure that you're using the right voicemail. You still have to have some policies and rules as to how much information you're going to leave on a voicemail. So a lot of the same issues crop up in you know, older technologies as they do in email. I mean, a lot of the same principles apply.
Yeah, like if you're a healthcare provider and you phone a patient, given the choice between saying, you know, Brian Hamilton, this is Dr. Work's office, please call, that's one thing, and saying, Brian Hamilton, we have your tests back, and it looks like you have, I don't know, pernicious anemia, and et cetera, you know, obviously you know which is the preferable way to handle your voicemail. And I think the same thing would apply to email. You disclose minimal information and you know, try to make sure that the information is limited, and that when there is disclosure, it is to the right person.
Yeah, that's okay. We got our connection back, so that was the last one.
That was it.
Yeah.
Well, excellent. Well, thank you so much. This has been very, very informative.